Hi, I'm Deb DeSenza. I run preemieworld.com, and I'm excited to be able to interview a very special neonatologist. I'm a big fan of hers, Dr. Melinda Elliott. There she is. I'm going to be asking her a number of questions, some that were submitted by some parents. And first, I'm going to ask Dr. Elliott to introduce herself, tell us a little bit about her background. Go ahead.
Hi, Deb. I am so happy to be here. I think, as you know, I am also one of your biggest fans. And what you do for families is so critical. So I am simply a neonatologist. I have been a neonatologist for longer than many people have been alive, over 30 years. And I love it. I love the babies. I love everything about it. And I am also the Chief Medical Officer for Prolacta Bioscience. And I am their Chief Medical Officer because I saw firsthand in my own unit what Prolacta fortifiers did for my patients. And I had the opportunity to start working with them. So I did, but I do still practice, not full time like I used to, but I'm actually going to be on service next week.
Okay, she's busy. She's busy. Well, wonderful. It's great to have you here, and your passion just comes right through. It always does. Whenever I hear you speak, it always comes right through. So I recently published the second edition of the Preemie Parent Survival Guide to the NICU. And in it, I highlight the tremendous clinical evidence to support a 100% human milk-based diet that includes mom's milk or a pasteurized human donor milk. It can also include a human milk-based fortifier for those babies that are 1,250 grams or less, roughly 2.5 pounds. Dr. Elliott, can you tell parents, help them understand why these babies need this extra nutrition that Prolacta provides?
Absolutely. That is such a wonderful question. Babies need extra nutrition over and above what mom provides in her milk, simply because they have so much growing and developing to do. The babies we're talking about come 2, 3, 4 months, sometimes even 5 months early, and they're very tiny. They are, like you said, under 3 pounds at birth and very immature. And no matter how hard mom tries, and I mean, she could chew on nails and eat nothing but, I don't know, bologna sandwiches, and she still couldn't have enough protein and fat in her milk that her baby needs to grow. So fortification is necessary. It's like sort of supercharging mom's milk by adding fortifiers.
Right. Good. So what is a human milk-based fortifier? People toss this word around a lot, and you hear different versions of what a human milk-based fortifier is. Like some companies say they have it, but they really don't. What's the difference? There's like traditional formula, and then there's this fortifier.
Yeah, so you're going to hear people say HMF or human milk fortifier. So what that simply means is something to add to mom's milk or pasteurized donor milk that gives it that boost. The problem here is that it's called HMF, or human milk fortifier, and up until Prolacta came around, it was made from cow's milk. So even though it's called human milk fortifier, it's not actually human milk-based fortifier. Prolacta Bioscience is the only company that makes a human milk-based fortifier. They make it from donated human milk.
Good. So when I had, and thank you, when I had my daughter Becky, she was 10 weeks early. She's now 17. Oh my God. And I was able to pump and give her enough breast milk. And I was very excited because the nurse had said, it's liquid gold. And I felt like I'd won the lottery. I was like, yay, go me. And then I happened upon the NICU to feed my daughter one day, thinking I was going to give her my breast milk. And there's a bottle of baby formula and I'm supposed to give it to my daughter. And I'm thinking, what, wasn't I supposed to be the best thing for my daughter? Isn't this liquid gold? And no, it's not. So really, it was very frustrating to me to have that happen. And apparently this has not changed. This is still going on. Can you talk to me about cow's milk, what that cow-based fortifier is, what it does to these fragile preemies?
So you are so right, and I am so sorry that that happened to you, even though I know that you and Becky weren't in my unit. But it should never happen to families. families should always know what their babies are getting. And so we used to only have cow's milk. So if for whatever reason mom couldn't make enough milk, then all we had was a cow milk based formula. And that was certainly better than not feeding the baby. I mean, the reality is you have to feed the baby. But now there are options, and I'm happy to say that there are somewhere around 30 to 40% of NICUs in the US and others around the world who actually do have human milk-based products now, and they can give them to the babies. But I firmly believe that every NICU parent should be informed about the risks of cow milk, because I believe they're real. And those risks of cow milk are way bigger than anyone really likes to talk about unless you're in the middle of all this science, right? And, you know, we all drink cow milk, or at least many people do once we're older.
Yes, but I had to witness firsthand as my daughter got diagnosed with sepsis. And it came after she had that cow-based fortifier. We almost lost her. And I never connected the dots until years later. And then I went, I was the best thing for my daughter. I was. But what she needed wasn't on the market yet. So, so that was really important. So where do parents go to find the clinical evidence to support this evidence and this research and this product?
A good place to start is the Prolacta Bioscience website. So that's www.prolacta.com. And what parents can find on there are actually a number of really wonderful things. First of all, you can find the scientific articles there. You can find the articles that talk about the risks of cow milk, the increased incidence of really bad problems like sepsis that Becky had, or something called necrotizing enterocolitis that affects the intestines of the baby, or something called bronchopulmonary dysplasia, which affects the lungs, or retinopathy of prematurity, which affects the eyes. All those things are less in exclusively human milk-fed babies, those babies that receive the human milk-based fortifiers. There's other great things on that website for parents, though. There's the Peekaboo ICU app, which they can use to basically document their baby's journey through the NICU. And then there are resources. There's links to many of the parent sites and the things that you guys all do that just are so important for families as they navigate the NICU.
Yeah, it's what I would have wanted. It's what I wish I'd had.
I wish you did too.
Yeah, exactly. So how do you advise parents advocating for that baby? So you've got that parent, they're reading up on the research, they're on the website, they're like, okay, what do I do now? How do they approach their doctor? That's very intimidating.
It's very intimidating. And I think the first thing I want to tell parents is that I can't imagine any doctor or nurse or anybody else that works in the NICU ever doing anything bad to a baby. And I have had families tell me that they're afraid to bring things up because they're just afraid somebody's going to take it out on their baby. And I get that fear. But first of all, no, I don't think it would ever happen. I really don't. So don't be afraid. Don't be afraid to ask those questions. Bring the information with you. Bring your specific questions. Ask for a family meeting. Sometimes parents get a little or a lot of pushback. And one way around that is to find yourself a champion in that unit, whether it's the nurse, the dietitian, the occupational therapist, the neonatologist, even a resident or a fellow. I mean, there's going to be somebody in there that you relate to. The lactation consultant, that's another one. Somebody that you relate to and say, hey, I need your help. I need your help bringing this up to the group. I feel strongly that my baby needs these human milk-based fortifiers, and I really want to talk about it and get some real answers. And I feel like I've been brushed off.
Totally agree. Totally agree. Wonderful. Okay, so I was reading up on some research recently around antibiotic use and breast milk. Can you tell me a little bit about that? Because I worry about a bunch of parents. I didn't have antibiotics, but I know a lot of moms do, and they have babies in the NICU and they're trying to feed them. And if the breast milk is not sufficient because of the antibiotics, what do you do? I mean, this is a perfect solution.
So it's a really complicated question, and I loved that you sent me that article to look at, and it's spot on target. I mean, it's very true. So the first piece of information here that is in that article is that the women who really had big changes in their breast milk were women who were on long-term antibiotics. So first of all, if you need antibiotics to kill an infection, then you need antibiotics to kill an infection. So part one is, if you need them, you need them. But really the bigger point is that there are other things that can be done. For instance, not feeding the baby cow's milk, giving mom's milk and giving human milk-based fortifiers, because there are things in that milk. The microbiome, or the bacteria, the germs that normally live in mom's fresh milk, they will be dramatically changed by long-term antibiotic use. And that's kind of what that article was talking about. But it doesn't mean that all is lost. There's still plenty of good things left in mom's milk, and it can be complemented by human milk-based fortifiers or other human milk products to kind of boost it up. But equally importantly, it's good to ask the doctor, for the mom to ask her doctor, help me understand why I need these antibiotics and how long do I need them, and do I really need 2 weeks, or would 1 week be sufficient, or is 48 hours enough? I mean, it's good to ask your doctor.
Yeah, it's learning to be an advocate, not only for the baby, but yourself. Yeah, absolutely. So let's switch gears. Let's talk about a little bit about the NICU journey. And we got some questions from parents. This is questions parents all have. So how long after birth can parents generally see their preterm baby? We'll see how I match up with this.
So first of all, there's not one answer there. Partly, the short answer is they should be able to see the baby immediately, unless the baby is so very sick that the medical team is working to stabilize the baby and help them. But I can't remember a time that I did not make sure mom and dad saw that baby before I left the delivery room. It's so important. And in a perfect world, at least mom can reach her hand out and touch her baby and hold her baby's hand for just a few seconds. I mean, it's extremely rare that that can't happen. So ideally, they get to see the baby right away. Otherwise, certainly as soon as mom has recovered enough from delivery, she can come to the NICU and see the baby. Dad, likewise, should be able to get in there pretty quickly and see the baby. Some units have rules where they want to, they'd like to have an hour or two to kind of stabilize the baby. And part of that depends on how tiny the baby is and how sick.
Oh, yeah.
In general, though, parents are so important. You can't separate a baby from his or her parents. It's just critical. It's all part of being a baby.
It's so hard. It's so hard. Absolutely. So, and that separation is difficult. So the big question is, when can they hold them? Is that multi answers too?
Yeah, of course. There's always multi answers. But the reality is there's something called skin to skin care or kangaroo care, which more and more science is telling us it's so good for baby and for mom and for dad. I mean, it's so good for so many reasons. And what that means is that your baby sits right on your chest, wearing only his or her diaper, or maybe a little hat too to stay warm, and goes right on your chest, like under your hospital gown. And it really is skin to skin. It's why they call it kangaroo care, if you think about kangaroos in their pouches for their babies. And we know that that's good for baby because it's stabilizing. We know it's good for mom because it helps her milk to come in. We know it's good for dad because he feels like he's part of this process. So skin to skin care can happen pretty early. Babies can still even be on ventilators or breathing machines as long as they're stable. You can do skin to skin care. It requires a team, but the team can do it.
I loved kangaroo care, and I was the one that had to push for it, even though I didn't know what it was. I was like looking around, like, where's the kangaroo? What this? I'm told by my mother-in-law. Wonder when you're going to do kangaroo care? Where's the kangaroo? Sure, I want kangaroo care, and all of a sudden, there she is, and it was amazing to watch her vitals like normalize on the monitors as she was on my chest. And yes, my milk definitely came in. That was
So
impressive. So, yep, can't say enough about it. So, okay, so if parents don't know what's happening with their baby, what can they do to advocate, talk with the doctors and talk about that? And so they can understand the medical plan. What's the best route to doing that?
ask questions. And honestly, there's nobody keeping track. You can ask the same question over and over until you understand the answer, because you as a parent are the one that deserves to understand that answer. And occasionally we doctors slip into medical jargon and you may not understand. And that's not your fault. That's our fault. And you got to say, wait a minute, I'm sorry, I didn't understand that. Please explain that again. Some units, babies might have a primary nurse, and in that case, that nurse might be a really great resource to answer a lot of questions. It's a good time to remember that the NICU nurse is also there for you. And you know, as a doctor, as a neonatologist, I just want to apologize if a parent ever gets brushed off, because parents are the key to good outcomes for their babies. And we need, as physicians, to answer all your questions. So just keep asking them. And if you don't feel like you're getting an answer, another thing you can do is ask for something called a parent meeting or a team meeting, or, you know, places have different phrases for it. But what it really means is that somebody from sort of every discipline gets in the room with you. So like the doctor, the nurse, maybe the nurse manager, maybe the lactation consultant, or the occupational therapist, or any subspecialists that might be working with your baby. They are all in the same room. And you can ask them all any questions you want, and they can go over your baby's course.
Very good. Wonderful. So how long are babies usually in the NICU? I know that's another multi-answer question. And what milestones need to be achieved before they can come home? I think I know this.
I'm sure you know this. So the first answer to how long are they in the NICU is dependent on how early they were born. So when the baby's first born and is born very prematurely, your ballpark time in the NICU would be about the length of time until your due date. So I always say your due date plus or minus 2 weeks. Now that's what I say to parents when babies are first born. But as the baby goes through his or her course in the NICU, that answer could easily change. If the baby does super well, then they might get out of the hospital earlier. If the baby has some complications, they might stay a little longer. So it's a moving target, but a good ballpark is your due date, plus or minus a couple weeks.
You put that really well. Nobody ever told us that. They didn't
Oh,
talk about the fact that the target could move. They just
yeah,
told me by your due date. It's like, okay. So,
yeah.
so tell me about Prolacta. How does Prolacta aid specifically with BPD or bronchopulmonary dysplasia? Big long word. And apart from facilitating growth, do the nutrients provide therapy for chronic lung disease at all? Are there antibodies in Prolacta's fortifiers?
So that's somebody who's really smart and thinking about this, asking this question. So the
Not me.
short answer is, it could be you. The short answer is that BPD or bronchopulmonary dysplasia is a disorder of mostly premature infants. And it's because when they're born, their lungs are not nearly fully developed. And many tiny babies need help from a breathing machine or a ventilator. And while that machine helps those babies, it also can cause harm. And so there are a whole lot of things involved in causing BPD. However, the healthier a baby is in the NICU, even if you're very tiny, and the fewer problems that you have, the less likelihood of having BPD. On top of that, there are nutrients that are in human milk that help stabilize some of the membranes in the lung. We do not know exactly what all those nutrients are, but we do know that babies that receive an all human milk diet and are not exposed to cow milk have a significantly lower incidence of BPD. And then on top of that, yes, there are antibodies in human milk. There are antibodies in mom's milk that are against things that mom herself has been exposed to. And then there are other antibodies in the human milk-based products that are from the women who are donors. So you get actually a fairly big breadth of antibodies. And we don't know if the reason babies are, for instance, less likely to get sepsis is because of those antibodies or because of something completely different.
Very true. With Becky's case, it was something else. It was something else. Okay, let's talk about discharge. The big day.
Yeah.
Where they do graduation caps and gowns now, and we
Photo
didn't
shoots, the whole 9 yards.
get that. So we were educated, and as we were prepared to take her home, but we were scared to death. Okay, make that. I was terrified because she came home on medical equipment, and I was like, "Oh my God, I'm now a doctor." And I thought, what are these people doing? What are they thinking? Handing me this baby? Oh my God! So we faced taking her home with all this stuff. And we left the NICU. We left all these people behind. We wanted to take them home. What's the one thing you want to reassure parents about as their baby is being discharged?
That you can do it. Absolutely, you can do it. I think, to me, I didn't answer your question fully earlier, like what the baby needs to do to get out. And it's fairly simple. They need to keep their temperature stable in a crib, a regular old crib, not needing an incubator. They need to not have something called apnea bradycardia, or not have events like where they forget to breathe or their heart rate drops. I mean, all that, those are all maturity things that they develop as they grow and get more mature. They need to be gaining weight on their food. And they need to be able to eat well most of the time. Sometimes babies do come home on tube feeding, but most of them come home feeding. And so those things all go together. But with babies who have medical needs, like when Becky came home and you brought home your nursery equipment with you, you need to have the opportunity to spend some time with her in the NICU. Most units have a way for families to room in with the baby where they're not looking at the monitor and looking at what's happening. You only have the equipment you'll have at home, and you at least get a night or two of sort of practice with the rest of the NICU nearby, should you feel suddenly, you have a crisis of confidence. I haven't had a family ever tell me they weren't scared. It's so normal, and I get it. I was lucky I never had a preemie, but I can only equate that to, bringing my mom home from rehab and she could hardly walk. And I'm like, what am I supposed to do?
Yeah.
and then they say, oh, we'll send home health nursing, and they come twice a week, and you're like,
Exactly.
what about the other 5 days of the week? And so,
So the takeaways, even Dr. Elliott's nervous in a
yeah,
different.
yeah.
Yeah. So there we go.
Absolutely. That's the takeaway. It's
You.
normal to be nervous.
Thank
Just
you,
ask
Dr.
questions.
We appreciate it. And everyone, when you're not checking out Prolacta.com, check out preemieworld.com. Thanks.
Thanks, Deb.